Theophylline in asthma and COPD. Asthma and chronic obstructive pulmonary disease, COPD, are significant global health burdens, affecting over 300 million and 64 million people, respectively. Theophylline, a methylxanthine derivative, plays a crucial role in managing these conditions by relaxing airway smooth muscles and reducing inflammation. Diagnosis involves a combination of clinical assessment, spirometry, and laboratory tests, with a forced expiratory volume in 1 second (FEV1) of less than 80% predicted being a key criterion. Primary management strategies include bronchodilators, inhaled corticosteroids, and, in select cases, theophylline, with a typical dose of 200 to 400 mg orally every 6 to 8 hours. Key points. Note: theophylline is used in asthma and COPD at doses of 200 to 400 mg orally every 6 to 8 hours. The therapeutic plasma concentration of theophylline is 5 to 15 mcg/ml. Asthma affects approximately 8.4% of the U.S. population, with a higher prevalence in females, 9.5%, than males, 7.2%. COPD is the third leading cause of death worldwide, with a mortality rate of 3.2 million deaths per year. The FEV1/FVC ratio is a critical diagnostic criterion, with a value of less than 0.7 indicating airflow limitation. The Global Initiative for Asthma, GINA, recommends a stepwise approach for asthma management, with theophylline considered as an add-on therapy. The Global Initiative for Chronic Obstructive Lung Disease, GOLD, classifies COPD into 4 stages based on symptoms and FEV1 percentage, with theophylline used in select cases. Theophylline has anti-inflammatory properties, with a reduction in interleukin-4, IL-4, and interleukin-5, IL-5, levels by 25% and 30%, respectively. Monitoring of theophylline levels is crucial, with a target range of 5 to 15 mcg/ml to minimize toxicity. Theophylline can interact with other medications, such as ciprofloxacin, which can increase theophylline levels by 25%. Pregnancy safety category for theophylline is C, with recommended doses not exceeding 200 mg orally every 12 hours. Overview and epidemiology. Asthma and COPD are significant global health burdens, with asthma affecting over 300 million people and COPD affecting over 64 million people worldwide. The global prevalence of asthma is approximately 4.5%, with a higher prevalence in developed countries, 5.5%, than in developing countries, 3.4%. COPD is the third leading cause of death worldwide, with a mortality rate of 3.2 million deaths per year, accounting for 5.9% of all deaths globally. The economic burden of asthma and COPD is substantial, with estimated annual costs of $56 billion and $49 billion, respectively, in the United States alone. Major modifiable risk factors for asthma include smoking, relative risk, 1.8, obesity, relative risk, 1.5, and exposure to air pollution, relative risk, 1.2. For COPD, major modifiable risk factors include smoking, relative risk, 10.4, exposure to air pollution, relative risk, 2.5, and occupational exposures, relative risk, 1.8. Pathophysiology. The pathophysiology of asthma and COPD involves complex interactions between airway smooth muscles, inflammatory cells, and neural pathways. In asthma, the airway smooth muscles are hyperresponsive, leading to bronchoconstriction and inflammation. Theophylline, a methylxanthine derivative, relaxes airway smooth muscles by inhibiting phosphodiesterase (PDE) enzymes, which break down cyclic adenosine monophosphate (CAMP) and cyclic guanosine monophosphate (CGMP). Theophylline also has anti-inflammatory properties, reducing the production of pro-inflammatory cytokines such as interleukin-4, IL-4, and interleukin-5, IL-5. In COPD, the airway smooth muscles are also hyperresponsive, and theophylline can help relax these muscles, improving lung function. Clinical presentation. The classic presentation of asthma includes wheezing, 85%, coughing, 75%, shortness of breath, 70%, and chest tightness, 60%. Atypical presentations, especially in the elderly, diabetics, and immunocompromised, can include cough variant asthma, where cough is the sole symptom. Physical examination findings in asthma include wheezing, sensitivity, 80%, specificity, 90%, prolonged expiratory phase, sensitivity, 70%, specificity, 80%, and use of accessory muscles, sensitivity, 60%, specificity, 70%. Red flags requiring immediate action include severe respiratory distress, oxygen saturation less than 92%, and peak expiratory flow, PEF, less than 50% predicted. Symptom severity scoring systems, such as the Asthma Control Questionnaire, ACQ, can help assess disease control. Diagnosis. The diagnosis of asthma and COPD involves a combination of clinical assessment, spirometry, and laboratory tests. The step-by-step diagnostic algorithm includes 1. Clinical assessment, 2. Spirometry, 3. Bronchodilator reversibility testing, and 4. Laboratory tests such as complete blood count, CBC, and blood gases. The FEV1/FVC ratio is a critical diagnostic criterion, with a value of less than 0.7 indicating airflow limitation. Imaging studies, such as chest X-ray and computed tomography, CT, scan, can help rule out other conditions. Validated scoring systems, such as the Wells score for pulmonary embolism, can help assess the likelihood of other conditions. Management and treatment. Emergency stabilization involves administering oxygen, bronchodilators, and corticosteroids. Monitoring parameters include oxygen saturation, respiratory rate, and PEF. Immediate interventions include nebulized bronchodilators, such as albuterol, 2.5 mg every 20 minutes, and systemic corticosteroids, such as prednisone, 40 to 50 mg orally every 24 hours. Theophylline is used as an add-on therapy in asthma and COPD, with a typical dose of 200 to 400 mg orally every 6 to 8 hours. The mechanism of action involves relaxation of airway smooth muscles and reduction of inflammation. Expected response timeline is within 1 to 2 weeks, with monitoring parameters including theophylline levels, target range, 5 to 15 mcg/ml, liver function tests, LFTs, and electrocardiogram, ECG. Evidence base includes the OPTIM study, which demonstrated improved lung function and reduced symptoms in patients with COPD. Key points: pregnancy, safety category C, with recommended doses not exceeding 200 mg orally every 12 hours, and monitoring of theophylline levels and LFTs. Chronic kidney disease, GFR-based dose adjustments, with a reduction of 25% for GFR 50 to 75 ml/min and 50% for GFR less than 50 ml per minute. Hepatic impairment, Child-Pugh adjustments, with a reduction of 25% for Child-Pugh Class A and 50% for Child-Pugh Class B or C, elderly, greater than 65 years dose reductions, with a typical dose of 100 to 200 mg orally every 12 hours, and consideration of Beers criteria. Complications and prognosis. Major complications of asthma and COPD include respiratory failure, incidence, 10 to 20%, pneumonia, incidence, 5 to 10%, and cardiovascular disease, incidence, 10 to 20%. Mortality data include a 30-day mortality rate of 2 to 5% and a 1-year mortality rate of 10 to 20%. Prognostic scoring systems, such as the Bode Index, can help predict mortality. Factors associated with poor outcome include smoking, obesity, and comorbidities such as cardiovascular disease. Recent advances and emerging therapies, 2020 to 2024. New drug approvals include the use of biologics, such as omalizumab, 150 to 300 mg subcutaneously every 2 to 4 weeks, for severe asthma. Updated guidelines include the 2020 GINA report, which recommends a stepwise approach for asthma management. Ongoing clinical trials include the NCT 04234114 study, which is investigating the use of theophylline in COPD. Patient education and counseling. Key messages for patients include the importance of adherence to medication regimens, with a target adherence rate of 80% or higher, and lifestyle modifications, such as smoking cessation and weight loss. Medication adherence strategies include the use of pill boxes and reminders. Warning signs requiring immediate medical attention include severe respiratory distress, oxygen saturation less than 92%, and PEF less than 50% predicted. Lifestyle modification targets include a reduction in body mass index, BMI, of 5 to 10% at 6 months and an increase in physical activity of 30 minutes per day, 5 days per week. Clinical pearls. Note, theophylline can interact with other medications, such as ciprofloxacin, which can increase theophylline levels by 25%. Monitoring of theophylline levels is crucial, with a target range of 5 to 15 mcg/ml to minimize toxicity. The FEV1/FVC ratio is a critical diagnostic criterion, with a value of less than 0.7 indicating airflow limitation. Asthma and COPD are significant global health burdens, with a substantial economic impact. Theophylline has anti-inflammatory properties, reducing the production of pro-inflammatory cytokines such as IL-4 and IL-5. The GINA report recommends a stepwise approach for asthma management, with theophylline considered as an add-on therapy. The GOLD report classifies COPD into 4 stages based on symptoms and FEV1 percentage, with theophylline used in select cases. The BODE index can help predict mortality in patients with COPD. Theophylline can be used in pregnancy, but with caution and close monitoring of theophylline levels and LFTs. References. 1. Boylan P.M. et al. Theophylline for the Management of Respiratory Disorders in Adults in the 21st Century, a scoping review from the American College of Clinical Pharmacy Pulmonary Practice and Research Network. Pharmacotherapy. 2023, 43, 9963-990. PMID, 374237768, https://pubmed.ncbi.nlm.nih.gov/374237768. DOI 10.1002/FAR2843. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.